This is my talk on testosterone replacement therapy. And I tried several years ago to put together a talk which would help her from start to finish go back to her office and administer not just competent testosterone replacement therapy, but really get into it for their patients. Another good name based on the Woody Allen theme is everything I always want to know about TRT, but just didn't have time to ask with fighting insurance companies and filling out needless paperwork and so forth. So what is testosterone replacement therapy? In my opinion, it's restoration of testosterone to healthy physiologic levels. I'm a pure normal range kind of guy. Every patient has their own sweet spot, whether that's lower mid range or probably upper quartile of normal range, but I try not to go to the top of normal range except in certain specialty cases. It's not taking testosterone above the top of normal range specifically. That, in my opinion, is doing steroids, and I'm against doing steroids. And also, it's not Viagra. I admit, you put your guy on some testosterone gel, he probably just kind of follows it around for the next couple of weeks. Now, back to the subject of steroids, I just found this article on one of the message boards, on this picture on one of the message boards. This fellow is quite impressive. Now, guess which one he is in this picture?
Middle one.
He's got in the middle. Yeah. I think I don't know if he's passed yet from kidney failure or not, but if not, he will be in next year. Okay. So how do we screen for testosterone? What are the symptoms of low testosterone? TAT syndrome. You all know what that is. Tired all the time, right? We're talking about fatigue, obviously. Eustace syndrome, right? I used to be able to work well in the evening. Now by the middle of the afternoon, I'm all pooped out, right? I used to enjoy my family in the evening. Now after dinner, I lie down on the couch until it's time to crawl up to bed. My wife and I used to have wonderful relations. Now we don't even talk about it anymore. I used to be able to hit the golf ball 40 yards further. I haven't been able to do anything about the slice of the hook yet. Loss of muscle mass, which you lose in muscle, you gain in fat. Poor recovery, whether it's from a hard workout or mowing the lawn. Pain, inflammation, testosterone attenuates the pro-inflammatory cytokines. Irritability. Actually, when I look at my male patients, I love it when the wife is in the room sitting next to him, because when I ask him, are you irritable, I always look at her for the answer. I'm not irritable, damn it. Depression. Sure, you're weak, you're fatigued, you're impotent. What's not to be depressed about? Next one is, oh yeah, I've done this show before. Loss of libido. That should be a red flag with erectile dysfunction for low testosterone levels, a screening for testosterone. Okay. Here's the Adam questionnaire. One of the major pharmaceutical companies conveniently provides that for you for your office. Good to have that pad sitting around. But while the symptoms of testosterone, low testosterone, by Adam questionnaire, are sensitive, they're not very specific, unfortunately. So when I'll be back turns into oh my back, I don't know who hates that picture on the right. It's probably time to screen for testosterone levels. So what's the initial lab work? Here's my panel. I'm going to go through this whole thing for you quickly. The measure of testosterone, total testosterone. Testosterone is all that's being produced by the body. For practical purposes, let's call it 300 to 1,000 nanograms per deciliter. The most common use for total testosterone is to deny patients the testosterone replacement therapy that they need and deserve. I can't tell you how many times patients have come to me, testosterone is, for instance, 325. Doctor says you're normal range. Have some Viagra, have some Prozac. We'll see you in 6 years. Let's get metabolic and treat the cause of the disease. Free testosterone, that's 1 to 2%, maybe as much as 4% of the free testosterone in some patients. Of the total testosterone, I should say, in some patients. Make sure you're using equal dialysis, not the RA method, by the way. Bioavailable testosterone, that's the gold standard. That's the amount of testosterone the patient has down where the rubber hits the road. The concentration of testosterone which presents to the androgen receptor closely approximates the sum of the free testosterone and that which is loosely bound to other carrier proteins, primarily albumin. That's a big boy right there, aka free and loosely or weakly bound. So how do we find total testosterone or any testosterone normal, so-called normal range? Well, they bookend 2 standard deviations, right? Okay, we're going to show in a second here, about half the men over the age of 50 have low testosterone. So the guys are all sick and they're being added into the pool for normal testosterone. That's like gathering a potassium assay on a dialysis patient on the way in for dialysis and including that in so-called normal range for potassium. Nobody would do that. Why should it be any different for hormones? Give you a couple tips here, and this will all be in the notes from the lecture. When you're gathering your testosterone sample, It's a plain red top tube. It's very important. No SST, no serum separator tubes. So screw up your hormone assay. Okay. There's a couple general concepts here about estrogen testing. Total estrogens is not a valid assay for adult males. And I keep harping on that. Here's what I did. I compared total estrogens to the ultrasensitive estradiol assay. Similarly, I gathered ultrasensitive estradiol assays and compared to the standard estradiol that's normally run for females. I cannot tell you how many times the standard assays of total estrogen or standard estradiol were above the top of normal range when the ultrasensitive assay was mid-range or maybe even lower. What that means is a lot of doctors out there are incorrectly applying aromatase inhibitors, or just plain incorrectly applying aromatase inhibitors. We'll talk about zinc in a few minutes, to their patients when their estrogen is not low. What happens when you drive estrogen into the dirt? You have problems with endothelial function, and lipid panel, and the joints burn out, dry up, I should say. They get headaches. It's generally bad for health, and also libido dries up. So you must run ultrasensitive estradiol. One lab calls it ultrasensitive. One of the other major labs in this country calls it sensitive. They're both valid for adult males. Okay. The gold standard for estrogen testing is provided by the 24-hour urine panel because its nature of productivity is pulsatile, just like with testosterone. So, and also be mindful of sex hormone binding globulin level. Okay. So what are the sample matrices? Blood is the most common. You can give your total free and bioavailable, but you've got to appreciate the snapshot only. It has a very limited value when giving transdermals, where the serum levels for androgen and estrogen have a roller coaster effect. And also delayed reactions, for instance, in production of estrogen from testosterone. The urine, in my professional opinion, and certainly Dr. Gordon and I do things differently. Usually we discuss these things in conversations which are, for me, very, very late at night, given the time zone spread between Lansing, Michigan and LA. I try not to call him during the day because he's usually hanging out with some mucky-muck Hollywood type. But it really happens all the time. But the urines are nice because they are producing a free, maybe something closer to a bioavailable assay. Certainly the hormones that are separating the blood and being filtered by the kidneys. But there is at this time a limited number of assays. They're working on it. And some of these expanded hormone assay types, that you can get from the urines, all these metabolites you can use to actually try to get a feel for what the intracellular hormonal activity is. You have to be careful of contamination. Two things happen. There's a dear old friend in the room who first explained this to me about 5 years ago. Your patient comes in, you've got him on a testosterone gel, and his testosterone level comes back looking like he's on steroids. What happened? He doesn't look like he's on steroids. Yeah, he spread on the antecubital fossa. When the needle went through that little tiny plug of skin containing enough testosterone that jacked his levels up to 3, 4, 5 times the top of normal range. Here's another thing happens. Your male patient puts on his testosterone gel, or his female, I guess, female patient, puts on a gel, and then they urinate in the jug. They didn't wash their hands first. One tiny little flake of testosterone falling off their hand into the jug will contaminate the specimen. That's how sensitive these assays are. It's just like with a saliva prep. If you put in testosterone gel, you shouldn't lick your fingers. Many, many, many times guys come to me because their primary care doctors or even their endocrinologist or urologist refuses them testosterone replacement therapy when they have all the symptoms of hypogonadism. And they'll show me the labs. And I see why the physician did that or didn't do that, because their testosterone level is mid-range. Well, I run a 24-hour urine panel on them, and I find out their testosterone can be quite low once you gather the area under the curve. So maybe what they did is just have to catch him at the peak of the roller coaster ride in the morning, and that basically is all the guy had to live on all day long. Well, when in the day do we need our testosterone? When's our chance for romance? In the morning we're getting kids ready for work, or going off to work, I should say. No, in the evening, that's when we work out. That's when we have a chance for romance, maybe, right? And that's where testosterone characteristically is lowest.